about RSV, which is not new to public health or to physicians, but might be new to members of the public and young families. And we talked about prevention, and I want to kind of use those three pillars again today. I want to tell you about the state of our local and regional healthcare system. I want to talk more broadly about respiratory season. So RSV is still a big player, but I want to broaden that lens to influenza and COVID as well. And then after you hear from our two my physician partners here, I will talk with some very explicit prevention recommendations for everybody. So let me just share with you, we've used the word unprecedented a lot in the last 3 years. So it's hard to know how to ratchet that up. We are at what our people are calling a historical moment in terms of the pressures on our local healthcare systems. Again, I don't speak directly for the hospitals, but I do have a lens into emergency medical services, which is hosted by Multnomah County. And I can tell you that our EMS medical director shared with me that essentially all emergency departments are full with full waiting rooms. And so this has really signaled a high demand for hospital and emergency level care that is at risk of really going beyond the supply that we have locally. And we know that what we're calling supply is really both space and staffing in our various healthcare facilities. It is incredibly stressful for healthcare providers and anybody working in public service and healthcare service delivery in particular. And so I want to thank all of those workers and really send my thoughts to everybody who is ill, who is waiting for care, probably as we speak. Again, the driver of this, we're going to talk about RSV. It remains a major concern among children, in particular among those under age 5, although we do also see RSV in adults, and we have seen hospitalizations among adults. The hope is that we might be nearing the peak of RSV season, but as we've said before, with peaks, it can be a long way down. And what's most concerning to me is that right behind it, we see indicators for influenza activity and hospitalizations on a very steep upward climb. Again, influenza affecting young children as well, but also adults and the elderly. And on top of that, a sort of surprising uptick in COVID-19 hospitalizations as well. So this is all straining our acute care and emergency care resources in the region. And so I want to be really clear on what the public can do to prevent these illnesses. But first, I really want you to hear first from Dr. Eriksson about what he's seeing and working on in his role at OHSU. Go ahead, Dr. Eriksson, and thanks again for being here.
Thank you, Dr. Vines. So as I think many of you know, RSV has been circulating at very high rates in our community and has been causing a high number of hospitalizations among infants and children. We are really facing a public health emergency as the governor declared a couple of weeks ago. And it's one that's really straining our healthcare system and at points threatening to overwhelm our pediatric healthcare system. Our staff here at Doernbecher are really amazing and working incredibly hard to ensure that every child gets the care that they need. And I think that's true of not only the children's hospitals, but hospitals around the state. Everyone's really pulling together and doing everything they can to make sure that we meet the needs of kids. I think this is a good moment to recognize all of the amazing work that's happening both in the children's hospitals and around the state in terms of serving the needs of kids. We want to avoid at all costs a situation where we're not able to provide care for the kids who need it. And so we are using our resources as creatively and flexibly as we can to make sure that when a child really needs our care, we're there for them. We know that a lot of parents and families are scared about RSV and are concerned about the state of the healthcare system. And I want to remind people that we are working very hard. The declaration of crisis in the children's hospitals was really about making sure that we can most effectively use our resources to make sure that we're providing care to all the kids who need us. Thank you. I think with that, I'll turn it over to Dr. Hasson to comment on how things are going at Randall Children's.
Thank you. So I echo a lot of what Dr. Eriksson is saying here. So we are at Randall seeing really historic numbers of not only admissions, but also emergency room visits. Our emergency room is seeing almost double some days of what they would see on a normal winter month. And I want to be clear that this is a large portion of this is RSV, but this is really the confluence of multiple respiratory viruses happening at the same time. So we are seeing high numbers of other viruses that can make kids very sick, like rhinovirus and enterovirus, parainfluenza. And we are seeing increasing numbers of influenza and COVID-19. In fact, I was working last night and I personally admitted 3 influenza patients to the ICU last night. We are seeing that those numbers are increasing exponentially. We at Randall have an absolute commitment to providing medical care to the children of Oregon and Southwest Washington, and we are doing everything we can to provide that care as creatively and safely as possible. We want to make sure that we're able to provide services to the children in Portland, but we also want to make sure that we're able to help all of our community hospitals out there who are doing a fantastic job at stabilizing these children. We want to make sure that we're able to create hospital beds for them as well. And I want to echo what you heard from Dr. Vines and Dr. Eriksson, that RSV, rhinovirus, enterovirus, influenza, all of these viruses are very familiar disease processes to the pediatric care community that are caring for these children. So this is not a crisis of the disease, this is a crisis of resources, meaning that we simply just don't have enough nurses, respiratory therapists, and support staff to provide the care that we have been traditionally been able to provide. And we are thinking very creatively to provide the care that we want to every patient that needs it in a safe manner. And I'm incredibly proud of what we've been able to accomplish at Randall. We've been able to deliver the care that every child needs. Last night, we had a record number of patients in our ER and only 2 patients left without being seen because we are doing everything we can to make sure every child is seen. But most importantly, what you can do as a community member is to prevent needing care altogether. And so I'd like to turn it back to Dr. Jennifer Vine to talk about ways that we can prevent overwhelming our healthcare system and prevent kids from needing healthcare at all.
Thank you so much, both of you. It's great to have your perspective and your voice with us today. And I want to extend my deepest gratitude, respect, and admiration for everyone working in healthcare right now at all levels of support for our healthcare systems. I do want to take a minute to talk about prevention, much of which will sound familiar. We are in winter in the Northwest. It is the indoor season, so being outside is certainly less appealing than it was a few months ago. So everybody 6 months and older should be vaccinated for influenza. And if you have a less than 6-month-old in your household, you want to make sure your entire household is vaccinated. That offers a buffer, if you will, sort of a protective cover around that infant. The COVID vaccine is widely available. The COVID booster continues to be a good match for the variant of Omicron that is circulating now. And it's never too late to start the COVID series. So if you've never been vaccinated for COVID, going and getting your first dose is a great risk reduction strategy. You can get it at the same time as you get an influenza shot. And those are both really good bets for staying well and, again, not needing hospital care. Again, if you are sick, stay away from others. If you're in a high-risk category, stay away from people who are sick and avoid crowds in general. We all know how to prevent the transmission of respiratory viruses because we've done it several times now throughout COVID and throughout the last 2 respiratory seasons. I want to emphasize hand washing, which has an important role in RSV prevention. RSV, less so than COVID and flu, likes to hang out on surfaces and unwashed hands. And so that is an important strategy to continue doing, whether it's with hand sanitizer or good old-fashioned soap and water. Finally, I want to make just a very simple and clear recommendation for everyone to return to masking indoors. And by that, I mean a personal, voluntary action across the board for everyone through at least the first of the year. And this is not a mandate. There's no enforcement here with it. I don't anticipate a mandate. I don't anticipate public health closures. I am not asking organizations to change their masking policy. I am not asking for a return to any kind of enforced social distancing. I'm asking for everyone, in addition to being vaccinated, washing your hands and taking other precautions, to just put a mask back on when you're indoors around other people. And that goes for kids in K through 12 school settings and childcare. So I just want to say that as a strategy to lower some of the burden on our hospitals, keep them from becoming overwhelmed, and also to acknowledge what we know about masking, which is that it tends to stabilize. It tends to stabilize schools, and it tends to lower spread of illness enough for essential functions to continue happening that we all rely on, whether we think about them or not. So I think with that, I'm eager to hear your questions or any questions that you have for the healthcare specialists that we have here with us today.
Thank you to all of you. I'm going to ask that reporters, if you have questions, please indicate in the chat. We'll answer questions in the order that they're received. Lisa.
Yes, hi. A question for any of you folks, but looking ahead down the road, if RSV is going to take some time before the case counts go down after the peak, and you've got flu now starting to surge, what's the worst case scenario you see going forward?
I'm happy to talk a little bit about what we might see. Yeah, I think it's important to acknowledge that, as Dr. Hasson mentioned earlier, we're seeing a lot of RSV, but we are also seeing increasing rates of children with influenza, and we are seeing children with other respiratory viruses as well. The other thing that's really important to mention is that right now we're being very thoughtful about how we provide care. So kids with needs that aren't necessarily ones that need to be met within the next few weeks are often being deferred so that we can focus on the kids who need us right now. That means that we're expecting that even after the peak of RSV, we're going to continue to see really high numbers of children in the children's hospitals for at least the next few weeks and potentially months. I don't know that we're going to see higher numbers than we are right now. It's really difficult to predict the future when it comes to that, but I certainly expect continuing high needs even as we see the RSV curve start coming down.
Thank you. So I see next up we have Amelia.
Yeah, I have two questions. The first is, you've mentioned overwhelmed emergency departments. I've heard that from many places, really long wait times. And I guess I'm wondering, do most of those patients need to be admitted, or could they be seen in urgent care or at pediatricians' clinics? And has fear of RSV actually kind of made the capacity problem worse? Is our messaging around RSV potentially contributing to the capacity problem in making people afraid for their children and maybe turn up when they don't need to?
Yeah, thanks, Amelia. I'll tackle this question. I think I do hear anecdotally certainly about concerned parents coming to emergency departments to have their child, checked out, just in case, which I completely understand that desire to be reassured in the face of an ill child. Certainly, if any parent thinks that their child is seriously ill, they should not wait or assume that they won't be seen or can't be seen. They should absolutely seek the care that they feel they need. For a child who is, mildly ill, and we've put out some guidance around this for parents and caregivers about when it's okay to watch and wait at home versus maybe start with an advice line as opposed to going to an emergency department. And I'm happy to share out again those resources because they can be very helpful and very reassuring to parents. And I'll let the bona fide pediatricians here chime in there as well. I think in terms of emergency response times, again, there's a lot of energy going into problem solving and how to distribute patients, those who come in by ambulance, making sure that emergency departments are able to take them, but the system is strained. There's no question. That does not mean that people can't, walk into an emergency department if they so choose. But we do start to see prolonged response times among our ambulances, and we have to watch that really closely and be working carefully with our hospital partners on the emergency department side. To your question about how many actually get admitted, I don't know the answer to that, and I'll give some airspace to my colleagues here.
So most recently, we've been seeing almost double our normal winter census in the emergency department. And when I most recently checked in with our emergency medical director, he told me that about 10% or slightly less than that are getting admitted to the hospital. They are seeing large numbers of patients who do not need true emergency care and could be managed either at their pediatrician's office in urgent care or even by phone. One thing I would like to emphasize is that there are reasons that patients should not be brought to the emergency room. One of those reasons is just for testing alone. A lot of patients right now are very concerned that, oh, I had my cousin got diagnosed with RSV and now my kid has a runny nose and I want to know if I have RSV. And I want to emphasize that seeking care for testing alone is not an appropriate use of resources right now and is contributing to overwhelming the emergency departments and urgent cares. And as long as your child is well appearing and just has general cold symptoms, knowing that your child has a specific named virus will not change the management for that child, because the management of all of these viruses is supportive care. And so unless there are severe symptoms, knowing the name won't help. And another reason to not present to care is for fever alone. We see enormous numbers of children who come to the emergency room just for fever. And in an otherwise healthy child without risk factors who's older than 2 months of age, fever alone is not a reason to seek emergency care and can be treated at home with ibuprofen or Tylenol or supportive care at home.
Thank you. Amelia, did that answer all your questions?
That did, thank you.
All right. And Annette, we see your questions in the chat, but first we're going to go to Fader.
Hi, thanks for taking my 2 questions. One, can you help us please understand the distinction of the scale of what you're describing when comparing adult hospitals to pediatric hospitals? Like, is this really fundamentally about the possibility that the pediatric hospitals will be overwhelmed, or is it more even across the board? That's number one. Number two, with the hospitals and ICUs, are any currently rationing care? And if not, do you expect they would have to? And if so, at what point?
I'm going to turn it over to Dr. Eriksson or Dr. Hasson to speak to this. I will just say, Fedor, I know enough to know that part of the pediatric plan has to do with keeping teenagers and older children in adult beds. So while we focus on our specific pediatric hospitals, there is a role to play among our adult hospitals that actually influences the functioning of our pediatric hospitals. And I'm sort of speaking out of turn, so let me turn it over to our experts.
Thank you. Yeah, part of what we're doing when we say we're using our resources as creatively as possible or as flexibly as possible is we're identifying kids who can be well served in areas outside of children's hospitals. So older teens, for example, with less severe illness can often be cared for pretty well in an adult hospital bed. We're doing these kinds of things to make sure that when there's a child who absolutely needs to be in a children's hospital, we are maximizing the likelihood that we can say yes. We are using all of our physical beds in our ICU at Doernbecher, and we'll start using additional beds outside of our physical ICU later this afternoon. We're doing all of these things to specifically avoid a situation where we have to ration care. So the goal here is that we are able to provide care for every child who needs our care. And a lot of what you're hearing about in terms of our flexing our resources, our crisis declarations, et cetera, are really about making sure that we are able to say yes when that child really needs our care. And I'll let Dr. Hasson speak for what's happening at Randall, but the children's hospitals are in frequent communication to make sure that we're collectively able to meet the needs of the patients who need us.
Yes, at this, we are absolutely not rationing care. We are doing everything we can to get every patient into a hospital. All 3 of the regional, particularly critical care hospitals, are in conversation multiple times a day, so that if we get a call for a patient, we're in conversations to make sure that we can find a bed for that patient. Particularly at Randall Children's Hospital, we've been working really hard to increase our ICU capacity by almost 50%. Throughout the hospital, we've increased our number of beds that are available. We have the ability to double room patients together. And so what we are asking from families is some grace from them during this time, because our goal is to provide medical services to every child that needs them. And as a result, unfortunately, we may not be able to provide some of the amenities that, Randall Children's Hospital is so proud to offer, like private rooms and things like that. And so certainly, we may not be able to provide a private room or a luxurious pull-out couch to families, but what we will be able to provide is the medical care that your child needs to heal from their illness safely.
I think this is really critical. Care may look a little different than it normally does. There may be longer waiting times for emergency care at urgent care, pediatricians' offices, emergency departments, and things may look a little bit different in the hospital. And the reason that looks different is because, again, we're doing everything we can to stretch our resources as much as possible.
What's the limit of stretching resources that Oregon's hospitals have right now? And do you expect or think that limit could be reached and rationing care would be required? Where's that line, and are we going to get there, do you think?
We're pediatricians. I'll let Dr. Hasson speak for Randall. I will say it is incredibly important to us to be there for the kids who need us. And we are going to continue to stretch to do everything we can to meet the needs of the kids who really need our care. So I'm very hopeful that we don't ever get into a situation where we need to ration care. We're working very hard, but we're not there yet. And I sincerely hope that we're not going to get there at any point in the near future.
If there's one thing I can say about the staff at Randall Children's Hospital and likely at the other children's hospitals as well, it's that we have grit and we have strength, and we want to be able to provide the care that every single child in Oregon needs. And so I am incredibly moved by the amount of extra work that people have been willing to put in to keep our hospital beds open. Nurses, respiratory therapists, physicians, everybody is picking up extra shifts, working extra long shifts, canceling personal plans, canceling vacations, working outside of their normal, administrative roles, working nights and weekends. People are making it happen so that we do not need to be in a situation where we need to ration care. There is nobody that wants to see rationing of care amongst children.
Thank you. And I would love to jump in on this question as well, Fedor, because it's one that we've had to examine at various points in the last 3 years. I hear you asking like what is the ultimate limit? And I think that depends. Unfortunately, when we see disease indicators climb in the community, that means healthcare workers are also potentially affected. And so just at a time when more people may be needing care, we may have more healthcare workers appropriately calling in sick because they too are affected. That's another reason for my recommendation that people mask in addition to other protective measures. I also think, we collectively together can affect this limit, right? This is, if people make behavior changes, if they make them urgently, we can also affect the demand side for healthcare while our partners are doing everything they can to make supply as available as possible. So I want to make it really clear that we all have a stake in this and we all have a role to play here.
Okay, thanks.
Thanks all. And it sounds like a lot of these responses addressed Annette's question about creative ways of dealing with cases, unless there's anything else that you all want to add before we move on to Annette's next question.
Well, if I could, how are you preparing for that possibility? Like if it reaches that limit, how are you preparing for that?
We are preparing for a lot of possibilities right now, but what I'd like to emphasize is what's in front of us right now and what the current needs of the community are. Right now, we're working incredibly hard to meet the needs of the community, and we're going to continue to do that.
All right, Fedor, did that answer all your questions?
Not quite, but I think I understand if we want to move on, but it doesn't quite, and we're focused on like the present moment. But I think understandably, Oregonians are thinking about what the projections are and what will actually happen and how it's being prepared for to reach if that moment is reached, and additional clarity on. I would imagine other people, say OHSU or Randall or the county, projecting out the number of days, say, given a rise in respiratory illness and given the resources that exist now, and given estimates on how they can be stretched, like are there projections on at what date potentially that limit would be reached for some hospitals?
No.
Yeah, Fedor, I think, we get forecasts. They're exactly that. They're forecasts. I know, are there worst case scenarios that we could talk about here? I mean, yes, but that's really not our message today. And I think that the main thing is that we can influence this. We can, thank our healthcare providers who are working on the supply side, and our appeal today is really to work on the demand side, so that we don't have to be having a conversation like this where we're talking about our worst case planning.
Thank you.
Annette, if you can, I'm going to ask you to use your microphone to ask any follow-up questions you may have.
Sure. If you could maybe just give us a list of how can a parent know this is really serious and it merits an emergency room visit versus, well, the kid has a fever. You mentioned that isn't necessarily the reason to bring somebody to an ER, but just to give us some clarity, especially for parents of young children.
Sure, I can take that one. So I tell parents that there are 3 things that they should look at when making a decision about whether to present to an emergency room. And the first is how hard that child is working to breathe. And so I recommend that parents undress their child down to just their diaper and take a look at how they're breathing. And if they're using their belly to breathe in and out, or they're using any of the muscles in between their ribs or under their neck to breathe, that's a child who needs to be seen in an emergency room for care. Other reasons to be seen are if your child is dehydrated. So for babies, we would say less than 3 diapers a day. That baby would need to be seen for hydration. And one thing we talk about a lot is looking at their level of alertness. So the third reason to bring your baby to an emergency room would be if they are no longer having periods where they're interested in eating or playing in between fevers. It's common when babies have fevers to be either sleepier or more irritable. But when their fever comes down in between, we want to see that they're waking up appropriately and are interested in eating and playing. And if they're not doing that, they need to be seen in an emergency room.
Amelia.
Yeah. Are your hospitals tracking the length of time that patients from outside the Portland metro area are waiting to get transferred into the ICU? How long it takes to transfer a patient from a community hospital that's not receiving the appropriate level of care there?
Yes, we're looking at this as we are from day to day. I think it's really important to mention that kids' needs will change, and so the doctors at both Randall and Doernbecher are taking a lot of calls from community hospitals and helping to both give advice about how to manage kids and then also making determinations about who really needs to be in the children's hospital. I would say in general, over the course of the last couple weeks, we have done a great job of keeping wait times really low for children who need critical care in one of the children's hospitals. That's really.
Do you have a wait list? Do you have like a unified wait list for the 3 children's hospitals?
We have a system where if one of the hospitals hears about a patient that they are not able to admit, there is a coordinated Oregon Medical Coordination Center system to help reach out to the other hospitals and identify who has the next available bed for that patient.
And I have heard that there is currently a wait list for some adult transfers. Is there a wait list for pediatric transfers currently?
Thankfully, at Doernbecher, as of this morning, there was no wait list for getting into the hospital.
Okay. On numbers question, I'd heard that last week, looking back at the whole week, hospital admissions for RSV actually declined a little bit from the previous week. Just looking at data for this week, that as it's coming in, it looks like it's kind of ticked back up a little. So we're kind of maybe at that peak, at that plateau. Is that how you are also reading that data?
Yes, we hope so. We got a little reprieve around the Thanksgiving holiday. We've definitely seen admissions increase significantly since then, and are hoping that we're very near peak, if not at it right now. Dr.
Okay.
if you have anything that you want to add to that.
I just wanted to speak back to the community hospital question, which is that, this is not a surprise to the pediatric community. We have known that this is coming for several weeks. And so we've been able to be very proactive about working with our community partners and preparing them for, meaning giving them guidance on how to manage kids that might be sicker or in their emergency room for a little bit longer period of time than they would be in other circumstances. And our community emergency rooms have been just absolutely phenomenal. And all of our facilities are doing everything we can to not leave kids who are providing acute needs in the community. And so if that means that we don't have a bed immediately in the hospital, then that's a kid that can come to our emergency room. We're trying to get kids to our facility in the doors, regardless of where that bed is, so that they are in our tower if they need to be.
Just want to thank you, Dr. Eriksson. Appreciate your time. And want to allow Dr. Hasson and Dr. Vines to share any last thoughts before we head out.
Thanks, everybody. Sorry to have to drop off.
So I just want to take this moment. I think actions speak louder than words. So I am not only a pediatrician, but I am also a parent to 2 young children who are in this at-risk category. I have a 7-month-old baby and a 4-year-old son who are at risk for all of these diseases. And so I've been doing exactly all the things that Dr. Vines has been saying. I'm being very thoughtful about what activities that I'm engaging in, meaning that right now I'm saying no to going to, indoor play places, indoor restaurants. I'm trying to avoid taking, particularly my baby, to crowded places like grocery stores or birthday parties and things like that. Hand washing. It's the first thing I make my 4-year-old son do when he walks in the house. And I am personally have been masking when out in crowded places. So when I go grocery shopping and things like that, to try and protect my own family.
Thank you so much again, Dr. Hasson. Yeah, I want to thank everybody for being here. I've said what I needed to say, which is to make sure the public understands the moment that we're at in our healthcare systems, and really for the first time in our pediatric healthcare system in particular, which I think is it's really a different ballgame.